Feels so good to be back in Athens. I really admire the whole team arranging this course, and I'm very grateful to be invited again. This lecture is going to be more practical than scientific. I was asked to talk about screw arthroscopic Latarjet, and these are my disclosures. So my first tip is to, if you want to switch from open to arthroscopic technique, is to prepare. So this is a picture of the master. The first thing I did was to go to Annecy and visit him, see how he did it. And after seeing him, it looked easy. It's not. So you should also perform in a wet lab. And of course, wet lab is sometimes more difficult than in the real world, but you have to do the procedure several times before you can do it on your patients. And also, I was lucky to do this with my mentor, Tom Ludvigsen, and we had some four-handed operations and some help in the first procedures. So I tried to copy the master, even though I do most of my shoulder surgeries in lateral decubitus. This one we started out doing in beach chair, and we try to make friend with our anesthesiologists because you really need to have a low, stable blood pressure. And you can also use tranexamic acid. And for some patients, it's a good thing to use muscular relaxation when you're going through the split in the subscap. And you can also see the two different pictures of the beach chair. We started out having the patient sitting almost upright, and then when we moved the camera from posterior to anterior, we had more like a lazy beach chair. So coming with the camera from posterior, you're more familiar with this position. Later in the procedure, you move the camera up front. But being posterior, you mark the height 3 o'clock, because then it's more easy to see where to place your graft later on. And you also remove the soft tissue and the bony spurs from the anterior glenoid. Another trick is to make a weakness in the subscapularis while you're still in the back. It's more easy to consider the height in the subscapularis, and you have the 3 o'clock mark. So then you release the tissue, follow the upper border of the subscapularis to find the undersurface of the coracoid. If you follow the subscapularis, you will find it, even if in a patient like this, where it's a lot of scar tissue. And when you then release the coracoacromial ligament on the top or the tip of the coracoid, you will expand the room underneath the deltoid, so you can see more. And of course, you have to continue and release soft tissue around the conjoined tendon. So still with the camera in the back, you see the humeral head down to the left and the subscapularis insertion, and you move on to release the tissue around the conjoined tendon in front of the subscapularis. Doing the screw technique, now we have moved the camera to the front, so you will look directly on the coracoid. And doing the screw technique, we always identify the musculocutaneous nerve as well. And looking from the front, the split between the pectoralis minor and the conjoined tendon is often a little bit more medial than you think. And when you find the right place, you will go into the fat tissue, and the nerve is right there. And it's always good to know where it is when you continue your release of the pectoralis minor. Here comes the needle to show the direction. We are about to make the portal to do the drill holes through the coracoid. And the needle is good to see the direction. And you can also palpate the tip of the coracoid, so you know that you're drilling in bone and not in soft tissue, because you should be at least 5 millimeters from the tip. And the guide is quite small and easy to get in with the screw technique. You use it to have approximately 1 centimeter between your Kirchner wires, and also to aim the direction. And in the beginning, we used 2 top hats in both tunnels, but we stopped doing the more proximal top hat because we saw that when we did the CT scan afterwards, after 1 year, there was a resorption of the proximal part of the coracoid. So the screw head and the top hat was then in like free air going into the subscapularis. So we stopped using the proximal and now only did the distal top hat. And we also realized that when we chiseled, did the osteotomy of the coracoid, often we had this spike underneath, and we spent a lot of time afterwards trying to form the coracoid. So then we started to use the curved chisel from underneath before we went on to chisel and do the osteotomy from the top. And very carefully, first the medial side, then the lateral side, and then the central part. So we saved a lot of time. We didn't have to form the coracoid later on. And of course, identify the axillary nerve, posterior to the conjoint tendon, anterior to the subscapularis. Down there, approximately where you want to do your split, is the nerve. So you better know where it is. Here is the switching stick coming from posterior through the joint, through the subscapularis, and you can see how close the nerve is. And to the right is the coracoid waiting to get through the split. But when you have this switching stick in the subscapularis, you can safely make your split lateral to the switching stick. And now, watching into the split, you come to the anterior surface of the glenoid. Maybe there are some more tissue that you have to remove, and you can also take the opportunity to flatten the glenoid surface even more, because it often looks a little bit different from posterior and anterior. In the beginning, we did a fixation of the coracoid with this guide and tried to drill the holes in the glenoid, but we struggled a lot with the direction because the tendon was pulling down. So we started to do the drill holes in the glenoid with just a guide like this. And we also had some issues where we were uncertain if we had drilled in bone in the lower tunnel. So drill the lower one first so you can feel that you're in bone. And we know that there's an issue if the screws are directing too medially, both because of the suprascapular nerve, we don't want to make any injury, and also if the screw heads are too lateral, it will give the patient osteoarthritis. So do it from the medial portal and the inferior hole first. After drilling the glenoid, we do the fixation of the coracoid to the guide. And with the Kirchner wire in the glenoid, you can stabilize the coracoid graft by threading it onto the Kirchner wire. It's much more stable, so it's more easy to do some forming of the coracoid with the shaver if you need to do that. And it's also much more easy to push it through the subscapularis split because you just let the wire lead the way for you. So here's the graft in place, and it's always a concern if it's lateral, medial, a little bit medial, it might be okay, but lateral might be a disaster. So if you are in doubt, you can remove a millimeter or two after you have done the fixation of the graft. So after we had done a little bit more than 100 cases, we felt that we had to look into our results, so we have published our learning curve. Everybody knows that this is a challenging procedure. So we compared the first 25 patients we did to the last 25 patients. And many of these were reoperations after Bunkards, and of course most of them were male. They all have more than several dislocations, median 10. So the results shows that the group were kind of similar when it comes to the patients, and the surgery time, fortunately, it went down, but when we started out, it was more than 2 hours on average for every patient. And both the preoperative and the VUSI after 1 year was the same for both groups, and the satisfaction of the patients were the same from the first until the last. We also counted the complications, of course. Bone resorptions happened in almost half of the patient. It's not necessarily influenced the results, but we see it in many patients. And when it comes to major complications, we counted all reoperation as major complications. So those 4 major complications in the first group, 2 of them were screw removal planned after many months. One of them was suspected infection, and one of them was arthrolysis. So fortunately, no nerve injury and nothing we couldn't handle, but you can also see that the numbers of complications went down for the last 25. We learned a lot taking CT of all the patients about placing the graft. So I recommend that, and also I recommend to cooperate with shoulder friends if you want to go into this demanding procedure. And of course, I would like to welcome you all to the ESCA Congress in Milan in May. Thank you.